PJ, the cloud or the computer? Record it to the cloud or? Okay.
If you use the cloud, we can just get it from anywhere.
Okay. So I think it's.
All right. So we'll get started quickly today, guys. So did everybody get a chance to eat something? No? All right. So no, you can't eat in here. I'm going to keep my mask on. If you can't hear me, let me know. I can talk louder. So we thought it was important, to talk about musculoskeletal imaging in the orthopedic interest group, musculoskeletal interest group, because this is something that you get some exposure to, in anatomy. I know your anatomy was a little modified last year, maybe a lot modified last year. You talk about cross-sectional anatomy, but you don't talk a lot about the particulars of acquisition of imaging, what some imaging is that really gets used, in common daily use in the hospital. Okay. For instance, does anybody know what fluoroscopy is? Raise your hand if you know what fluoroscopy is. I use it every day. What if I use the term C-arm? Does that mean anything to you? Right. Okay. So you need to know what these things are, because it's something that we use all the time in orthopedics. So we'll talk a little bit about image acquisition, and then we're going to talk about looking and describing images today. Okay. I had two versions of this talk. I had one that I liked a little bit better. That's basically this reorganized into a slightly different order. So if I seem off, we couldn't upload it in the last minute here. So basically, this is what I want you guys to try to understand today. And I want you to be aware of how to protect yourselves in the OR, because you will be exposed to x-rays in the OR and in the hospital if you're not careful. Okay. And as you're getting some clinical experience, some of you have sought out shadowing opportunities in the OR. Next year, certainly you want to make sure that you know how to play it safe. This list is incomplete. When we talk about musculoskeletal imaging, there's a lot of different ways for us to look at the body. What's the most glaring omission here? Think about obstetrics more than ultrasound. Okay, we use ultrasound a lot in orthopedics. I use them to look at little kid hips. I'm a pediatric orthopedist, so when I want to look at a hip that's not bony, I can use an ultrasound, and I can look for a cartilage shadow, and I can actually see if the acetabulum and the femoral head are together. Dynamically, I can put the hip through a range of motion and see if it moves. Okay, so some of these are dynamic and some of them are static. So the first one that you're familiar with, okay, going all the way back to Marie Curie and Röntgen and discovery of X-rays, is the idea of a plain film. Okay, what makes it a plain film? Well, there's nothing special about the processing afterwards. Okay, it doesn't have a grid on it, although most of them do now. And these days, how many of these are chemically developed? Virtually none. Has anyone ever seen a chemically developed X-ray? Yeah, they're mostly digital now. Okay, and you get them on a little file. Anybody know the file standard for imaging? DICOM. Have you heard that before? So it carries all the metadata about the patients, in the file, and they're generally encrypted. And so if you hurt yourself and got an X-ray of your hand and they gave you a disc to take home, chances are it's on a DICOM file, and that's universally portable and can be imported into medical records and things like that. When we talk about diagnostic X-rays, we're talking about a pretty small wavelength particle. Okay, basically this particle needs to bounce off or transmit around the atoms at the nuclear level. Okay, so these are wavelengths of 0.01 to 0.1 nanometers. And if you think about the size of an atom, okay, you're talking about on the order of angstroms, which is 1/10 of a nanometer, right? And so this is what's going to actually, in its wave, actually hit and bounce off of a proton. Okay, and we know that there are certain types of nuclei that probably shield us well from X-rays. Give me an example of something that shields well from X-rays. Lead, good, Superman fans. What else? What can we use as contrast? What are some other atoms that can be used as contrast? Iodine, okay, and barium, all right? Some of our X-ray gowns at the hospital are not made of lead, they're made of barium because it's actually lighter weight, okay? And if you have to wear it for a long time in the OR, you actually have a sheet of barium or even liquid barium in some of them. I forget what the melting point is. But the fact is that if you remember your electromagnetic spectrum, okay, X-rays fall really far out on the wavelength, which means their frequency is incredibly high too. And then the energy associated with them is very high. And why does that matter? Well, X-rays can cause damage to your DNA at a structural level, okay? Because when we talk about fractions of angstroms, now we're talking about resonating with the nucleic acids and potentially causing mutations, okay? That doesn't happen with microwaves. Microwaves, the frequency is, the wavelength is very very long, okay? And they can travel long distances, but they resonate at the size of water at a molecular level. So microwaves, why does your microwave oven work? Well, it makes the atoms oscillate and it cooks the liquid component on the inside and therefore cooks the food. Radio waves are actually very safe. They're around us all the time. Okay. And hopefully all the Bluetooth and, Wi-Fi stuff that we're using in radio waves is not going to lead to damage later on, but the data is pretty strong that radio waves are pretty safe. Okay. In fact, they are absolutely necessary to generate what you call an MRI image. But X-rays are high energy. Okay. So we have to practice safety when we're around them. And basically, when you think about a conventional radiograph and how it's acquired, you got your subject position. There's lots of different ways to position people to get the right view of a joint or a limb. And usually we want to get more than one projection. The rule in orthopedics is if you have one projection, you have no projections, because you can't comment effectively on what the body part looks like without having at least two projections. But basically you have an X-ray generator, which is usually a tungsten filament that basically have a capacitor charge, let this release into the filament, and then you get a discharge of X-rays, okay? You have devices inside of the generator that try to collimate that, prevent scatter so that the beam goes in one direction. And then you have a detector, and that used to be a chemical film, all right? And the way chemical film used to work is that when it was exposed to X-rays, it turned black. The film was white and it turned black. But where the X-rays bounced off, you got a shadow, and that was the white, okay? So the calcium in your bones, the crystalline lattice in your bones, depending on the density, would scatter it to a certain degree, and so that's how you got a negative image effectively of the limb. Make sense? Anybody do photography? So now it's digital photography, but this is how chemical photography used to work. So now we have electronic arrays. Like your peripheral brain in your pocket has a more complicated sensor array than the most complicated SLR cameras did, when they first came out 20 years ago, and it's packed on this tiny little microchip. And what we can do now is we can actually sense the X-ray photons with a similar high density array and process that information. You can get weighted averages, and you can do post-processing computing, and basically you're weighting pixels. All right. If you ever thought about how a picture gets made, it's about saturation and contrast, the weighting of the pixel, and the contrast to the adjacent ones. And we can actually manipulate those variables, on the post-processing too. But basically, we want to try to create a digital radiograph that looks just like the film, the other chemical radiograph, and they last forever if you have a place to save them. So when we take an X-ray, okay, what are we trying to look at? Well, we are trying to look at the structures in there. So we're looking at the pelvis, right? And I can see a lot of things here. I can see the outline of some of the anatomy, okay? So I think you all would look at that and say, well, those look like spinous processes, but I'm just looking right down the middle of it, so they're more dense when it hits a tangent and it's going through more bone. Well, wait a second. What about right here at S1? That doesn't look like it's closed. Well, that's called spina bifida occulta. The bone actually didn't fuse together there when this formed at 6 to 8 weeks of life during the process of neurulation and ossification of the vertebral somite. And that area right there is not fused. And I can pick that up on the X-ray. Okay? This doesn't affect this patient at all. That's not spina bifida, the neurologic problem. It's just a bony irregularity that maybe 2 to 5% of the population have. Now, what's going on the top of the pelvic rings right there? Can anyone describe to me what they see across the top there? When we talk about X-rays, we want to describe. What do you see? Yeah, so you see a radiodense line, the white line. Then you see a radiolucent line, the black line. Then you see the pelvis proper, okay? So what do you think that radiolucent, that dark area is? It's cartilage, the growth plate, okay? That is an apophysis. Did you come across that when you're reading anatomy? You remember what apophysis is? It's where muscles attach. It's where bones get bigger and grow out. So your tibial tubercle, your greater trochanter, your lesser trochanter, your olecranon, they're all apophyses. And that growth plate will fuse and disappear when this is a fully grown patient, okay? So there's a lot we can take from this, okay? But when I first see this and I say, Peter, I think I mean PJ, describe this to me, okay? You're gonna say this is an AP pelvis, right? Anterior to posterior of a skeletally immature patient, right? Can you tell it's male or female? No, you can't, okay? Can you tell anything important about it? Well, I'll give you some more descriptors, okay? The proximal femoral physes appear closed. The hip is well covered. The triradiate cartilage, which is a growth plate here, is closed, okay? So you can describe what you see. So when someone asks you about an X-ray, you want to describe what you see and think about how it applies to your patient, because you're going to correlate this with your physical examination, okay? Now, I wanted to show you some more tools. This is what we mentioned earlier. This is fluoroscopy, okay? Fluoroscopy is basically an X-ray, but it is an X-ray that has a lower dose of radiation. And you can see the setup on your left there. It looks like the giant letter C. So we call it C-arm. That's its nickname. Okay. The special drape we use to protect, from getting contaminated is called C-armor, and so on and so forth. But it basically connects to this device. This setup costs $250,000 to $350,000. The hospital has maybe 6 of these. Okay. They have some mini ones for things like hand. But what you can do with this is that there is an X-ray source down here. There is an X-ray detector up there, and you immediately get the information on the screen. Okay. And this is an example of an interventional radiology suite where you can do procedures like injections, or if that's a cardiac lab, you can pass a catheter in and then inject a contrast agent like the iodine we talked about before that your kidneys will clear quickly later, and you can actually light up the tree of the coronary arteries. That's what cardiac catheterization is all about. And they use fluoroscopy for that. Okay. Now there are special CT scanners and in some cases even MRI scanners, but a lot of special procedures when you hear that interventional radiology is getting done with the C-arm. And this is the workhorse in orthopedics. Okay. As you can imagine, a lot of the techniques that we use to fix fractures, especially when we try to avoid opening up the entire bone, because when you strip all the soft tissues off of the bone, you take away the periosteum and the blood supply that's critical to healing. Okay. And so using fluoroscopy, we can use minimally invasive techniques to visualize where there is bone, where there is metal, and how they relate to one another, and safely apply a device without stripping away all the biological substrate that's going to help that heal. Does that make sense? Okay, so C-arm or fluoro, you will see these machines in the OR. And when that machine's in the OR, you need to wear a lead apron. Okay, what parts of your body do you need to protect? Right, torso, thyroid, breast, gonads. Okay, and actually cornea too. Increased exposure to this can increase cataract formation. Okay, so many people who do a lot of fluoro every day, okay, I don't, probably should, actually have special leaded glasses for this too. But the idea here is that the X-ray beam is carefully collimated. Remember, collimation is when you align a beam in plane, you avoid stuff that scatters. Okay, a laser is kind of an example of perfect collimation. But this goes up and through the subject, and you get some scatter below the subject where it bounces off the bone, and then you get some scatter off that array. So the scatter where everybody's exposed is actually from above and not below the subject. Okay, people always say we got to put lead underneath the patient to protect them. Well, guess what? The lead underneath is not where they're going to get their exposure. It's actually the first bounce of the beam coming off of there. Does that make sense? So you look out for scatter, and you'll read about this process later on. But fluoroscopy is used in a whole host of settings. So when you want to study how someone swallows, have them swallow some barium and watch them chew. That's the other really cool thing about fluoroscopy is it's not just a static image. You can let it run and continuously record, and you can get video of things in motion. So you can watch the coronary arteries perfuse. You can watch an instrument being passed safely into a space. You can watch, trying to think of some other good examples. You can watch, like we said, a swallowing evaluation, all in real time. All right. So when I do orthopedic procedures and I want to make sure that something moves the way I expect it to, I can actually take fluoroscopy and make sure. Now, we can introduce contrast agents, like we said, and in orthopedics, we will often put iodine in. Okay. So that's fluoroscopy. Now, you're probably all familiar with computed tomography. Are you? Did you look at some cross-sectional anatomy last year in anatomy? First years haven't had it yet, right? Second years, raise my hand, first years. Raise my hand, second years. All right, hello, first years. Yeah, so you guys will see some cross-sectional anatomy, okay? So that patient on that gantry there is going into the CT scanner. And how does this work? Well, it is a spinning X-ray source, and opposite the X-ray is the high definition sensor array, okay? So they tumble around one another, and it actually rotates around in a helical fashion as it goes through the patient. And you will take a scout film to program how often you want to image, okay? Because they can actually repeat this, multiple, hundreds of times a second, okay, to get high resolution imaging. And basically, when you pass the X-ray beam through at one plane and then pass through at another plane and pass through another plane, you could have 2 or 3 sensors going at a time. You can create a coordinate map of density. The idea is that you're creating a 3-dimensional coordinate system that has a point in space that says, I am white. I am gray. I am black across the spectrum of grayscale. Okay. And what you do is you generate an image that looks like what you see on the screen here. All right. So what part of the body are we looking at there? That's the heart. Okay. Does it look like the heart's beating? Do you have a lot of motion degradation? Not really, right? How fast does the heart beat? 60 to 100 beats per minute, right? So it's a lot faster than that in terms of the image acquisition, okay? And the cool thing is that this is all done with a collecting this whole matrix of data or data points in space. And if you use Fourier transform, okay, everybody grown at once. Anybody take linear algebra in college? Right, okay, engineers, raise your hands. So yeah. So, you know, if you take those matrices of points and transform them, you can create two-dimensional, three-dimensional recons of this. And now we can 3D print these. Okay, it's pretty darn cool. So you can actually create a reconstruction and map this out. All right, and CAT scan has the finest resolution of any study, especially for bone. So we can change the contrast so we can see certain structures better. There are windows for air-filled structures, windows for blood-filled structures. We can add contrast if we want to. You know, abdominal CAT scans, pelvic CAT scans, they'll add oral contrast or rectal contrast, okay? And you can add IV contrast as well, so you can see everything light up and see the relative positions of everything. And you can get a good sense of where structures are relative to one another, okay? Really valuable to understand what's going on in the chest and the abdomen, okay? But sometimes we use it to understand what's going on with bony structures in orthopedics too. What are the problems with CAT scans? It's a lot of radiation, okay? Radiation is something we take really seriously. And if there's any one message that I want you to come away from today, it's image gently, okay? When you order a series of x-rays, you want to think about, why am I ordering all these x-rays, okay? You want to try to be as specific as you can. Sometimes you need 3 or 4 x-rays to make the diagnosis and make sure there's not other pathology. But you really want to be judicious in the use of x-ray, because cumulative exposure over time can lead to cancer, okay? Or radiation poisoning. Typically, you're not getting high enough doses for radiation poisoning, but a CAT scan lets you get this cool series of images. And this schematic kind of shows you how the high definition arrays spin in space. And then you're kind of stacking those images here, okay? And you are making this image that you can now manipulate and look at and gather a huge amount of data from, all right? So that's how CAT scans get acquired. And here you can see a tumor carefully outlined. And if you add contrast, this tumor will accumulate contrast in its periphery, and it will show you what's happening to the adjacent structures around it, and also where the blood is flowing in and out of it, okay? Anyone want to speculate what part of the body that tumor's in? Head of the pancreas, yeah. So often they have jaundice, gallbladder obstruction, clay-colored stools because there's no bile getting through, okay? So this is an example of a CAT scan, just kind of scrolling through slices. I like hips, so this is a hip. And I'm just kind of scrolling through this on my screen as I'm recording so you can see it. And as I get to this level, I can start to see the femoral head coming in, and I can look for irregularities. I can look to see if the hip is aiming backwards or forwards. So we're getting multi-axial imaging. I can image them in the axial plane, in the coronal plane, and in the sagittal plane. Okay, so axial is what we used to have, but with post-processing, now we can get coronal and axial recons that are pretty accurate. And it can give you a lot more information than you can get from just a plain film. But it doesn't mean you don't take plain films. Plain films add value. Each modality adds something different. This is another recon of the same scan. And you can see how this is a completely different look looking in the sagittal plane. And I can tell if that hip is a little retroverted and a little overcovered in the front. We won't go into that today, but it's a really valuable way to look at it. And then this is the coronal recon. So I can describe it in the same way: closed growth plates, good femoral head coverage, probably some retroversion. So a 3D recon will take all those series and make something like this. And you can actually play with it and rotate it around in space. You can even subtract out certain structures. You can map it out and say, I want you to remove the hip. And you can look at the acetabulum. I want you to remove the acetabulum and just look at the morphology of the femoral head. Okay? Pretty remarkable what you can do. Contrast agents we talked about on several occasions. We can give them intravascularly in the alimentary canal, intra-articular into a joint. So if I am doing fluoroscopy in the OR in a little kid, a lot of their joint is made of cartilage, right? So if I want to see the outline of the femoral head and where it sits in the acetabulum, and both those structures are made of cartilage, if I coat it with a contrast, I'll be able to see much better. And then I can do a dynamic study, turn on the fluoro and go live cine fluoroscopy, and I can actually see how those parts move relative to one another. I'll show you a little example of that shortly. I wanted to talk a little bit about MRI. You guys ever heard about the physics of how MRI works? A little bit, okay? So hydrogen nuclei, fluorine nuclei have a magnetic dipole moment. It's a fact of life. We're gonna take advantage of it, okay? If you put these molecules in a high magnetic field, and we're talking about the magnetic field of the Earth is about 1/7 of a Tesla, right? Well, a 1.5 Tesla magnet is 15 times stronger than that, and a 3 Tesla magnet is 30 times stronger than that, okay? You can align these molecules in a magnetic field when it's applied. If you zap them with radio frequency energy that matches the wavelength of that molecule, usually water or fat, and you can wait to what that radio frequency is and how long you wait to recover the signal. Those are the echoes and the other frequency modulations that you do with MRI. When you zap it with radio frequency, it flips out of alignment. See how the arrows are all pointing in different directions, kind of random. And then you release it, the magnetic field snaps them back into alignment and they release a photon of energy. And you can collect that data just like a CT does, and you can map out the density of hydrogen ions, okay? Sounds a lot like NMR. Everybody can really groan now from organic chemistry. Remember NMR? Well, it's a visual representation of NMR, okay, in real time. And it's not one pure chemical. It's actually looking at all these nuclei together. And when you take that information and align it, you can get a map like this, all right? That's pretty remarkable. It's not great for bone because bone doesn't have a lot of water in it. It's got some fat in it, but MRI is really good at outlining the anatomy of soft tissues, okay? And they each have different weights of gray, okay? And white matter and gray matter are actually not white and gray on MRI. But you can see how you can see different areas within the brain. I'll show you an example here. There's basically two flavors, okay? One weights towards the fat molecules. So bone marrow will be bright. Subcutaneous fat will be bright. Some of your abdominal organs will be bright. It shows the anatomy of the patient better. And then the T2 or stir weighted images, these are more weighted towards the liquid component and processes in which there is inflammation going on, okay? We talked about inflammation, right? Okay, what are the cardinal things of inflammation? Rubor, calor, dolor, Lacea function, right? Okay, when we're not talking about Latin, it's inflammation, right? What do you get? You get leaky capillaries, you get fluid going into a space, okay? So a tumor is gonna have edema, a fracture is gonna have a lot of edema. Blood will look bright on it, but blood may layer out because blood has a lipid component, all right? And it's got a liquid component. So sometimes the layering in an MRI can be instructive. So this is the same hip, looking at it in an MRI, okay? And what this shows me, I'm gonna loop this a couple times so you guys can see it again, is now I can really see the fluid around the joint. You see the white halo around the hip? So that's telling me there's extra fluid in the joint. And I'm gonna do a pause here. These are some tendons crossing in front of the joint. And this is the muscles around the joint. So it gives me a totally different perspective, okay? And the labrum is a tiny little triangle right there. I don't know how people say that it's torn on an MRI of the hip, but they do say that often. You have to correlate it with the patient's complaint. No image is meant to diagnose every problem, okay? You don't just get an MRI to find out. You come up with a good differential diagnosis of what you think is going on, and the MRI or the CAT scan or the X-ray is a tool to help answer the question and differentiate yes or no on a few critical questions that you have, okay? So you don't, patients will come in and ask you, why don't we just order an MRI? And I think that sometimes that's appropriate, all right? But many times it's not. And we have to kind of be the arbiters of when it's appropriate to use it and when it's not. And we know MRIs are expensive too, okay? They're a huge, component of healthcare costs. And there are times that it's appropriate to order an MRI, and you should when you believe one's noted. But when someone says, let's just get an MRI and see what's there, well, oftentimes you have to make sure that you understand what the indications are and what question you're trying to answer. And what happens if you find something you didn't intend to find? One of my co-residents, thought he had a little, disc herniation, which you're going to treat non-operatively. And he got an MRI and he found a benign retroperitoneal tumor, and he suddenly had to have surgery to have it taken out. Now, is he happy he had it out? Yeah. Would have done him any harm and stayed there for years without any problem? Probably, you know, you missed 3 months of work and, you know, had a big, you know, retroperitoneal dissection, which can have some complications. So, you know, you have to make sure you indicate properly what you're going after. So that image was more of a T2 weighted image, okay? And this one, the bone marrow is white. So why do we still see the fluid inside of the joint there? Sorry, I'm wrong. This is more of this is a different T2 weighted image. Where my cursor is highlighting right there, that is edema within the bone. That bone has femoral acetabular impingement, FAI, going on. So that's a bruise taking place right there. So the bone is showing evidence of bruising. And that's maybe that correlated with this patient's pain. And this patient had surgery to correct this deformity. So it answers a question for us. For MRIs, we can use gadolinium, which is a more uncommon elemental mineral. And this is safely eliminated by the body. Okay, there's questions about whether it can cause toxicity. Most people think no, but they do see it, you know, kind of aggregate in the some of the central nuclei of the brain. People don't know the long-term consequences of that, but gadolinium can be helpful to help highlight the vascular. So if you inject somebody right when you're about to take the MRI, you can actually see their blood vessels light up. So instead of doing a traditional arteriogram, we actually have to pierce, you know, their artery in their leg and then run the contrast and take a fluoro or a CAT scan. You know, you can do it with an MRA with contrast that's injected into peripheral IV, and you actually get a little better resolution and a better sense of where it's going in the soft tissues. So that can be really important. Generally, we want to try to protect ourselves from being exposed to too much radiation. You know, the average number of days lost of life, you know, is being exposed to 100 millirems, which is background radiation, for 70 years is about 10 days of life lost. Okay, but you start exceeding that value. Okay, a CAT scan can easily exceed that value by 5 or 6 times. Now you may potentially lose average days of life, you know, for a cancer that forms because of that. So we take radiation exposure really seriously. We should take it seriously for our patients and for ourselves. So we want to be careful. And radiation toxicity can occur at some of these really high levels. Now, the thing I lost here in translation with bringing this other talk up is I actually want to show you guys some examples of some x-rays that we can try to describe. Okay, how does that sound? And learn how to describe maybe what fractures look like. How does that sound? Good? All right. So I'm gonna use good old-fashioned Dr. Google. Questions about the material we covered already? All right, that looks bad, huh? So who wants to take a stab at describing this x-ray for me? I will help you, I promise. Anybody? All right, I will describe this one, then I'll give you the next one. This is a pseudolateral of a skeletally mature forearm, right side. There is a fracture of the radius and ulna that is angulated approximately 45 degrees in the sagittal plane. There is no shortening. Can I describe anything else based on what I see here? Not really, okay? Because I can't comment on a different plane. What about this x-ray right here? That one I can say, this is a displaced radius and ulna shaft fracture. It's transverse in the distal third of the radius. In the sagittal plane, it's angulated 90 degrees dorsal. In the coronal plane, there's no angulation and maybe a little shortening of the ulna. Kind of get the idea? There's descriptors for what you use to describe an x-ray.
Could you say that's mid-shaft, sort of in the middle of the bone?
Yeah, you could. I think that's accurate. Okay. Now, when I look at the radius and the ulna, I have to think about something. All right. And this is a principle that you guys should walk away with today. When you fracture the radius and the ulna, they work as a moving system. So if you only see one of them broken, the force has to get transmitted somewhere else. Same happens for the tibia and fibula. They usually break together. The force may break the other bone, but if it gets transmitted proximally and you break your ulna, you can actually dislocate your radiocapitellar joint or your distal radial ulnar joint. So in pediatrics, we see a lot of fractures called Montesia fractures, where kids will break their ulna here. You say, oh, that looks fine. But then if you look carefully, the radius doesn't line up with the capitellum. So you have to know to look for that pattern. And how do you make sure you don't miss that? Because you get called to the ER, you're the intern now, you get called to see this fracture. They have one picture for you. What do you want to order? You want to order a complete set of x-rays, AP and lateral view. You also want to image the joint above and the joint below. Okay, and that's generally a good principle. Okay, and as a student, that's what you should suggest. Okay, so someone comes in with a fracture of the femur. Okay, you're going to plan surgery for them. You come down, they have one picture of the femur. What are you going to order? AP lateral of the femur. Okay, an X-ray of the hip joint. Okay, and I'll tell you specifically what you do. And an X-ray of the knee. Why? Because the knee could be dislocated, there could be a distal fracture, the hip could be subluxed, but more importantly, there might be a femoral neck fracture 5% of the time there is. And if you miss it and you fix the femur fracture and you notice the femoral neck fracture later, guess what? You're going back to the OR to fix it. So when someone comes in for a high energy trauma in a motor vehicle accident, they have a femur fracture, okay, we will often get an X-ray with the hip internally rotated because it makes the femoral neck longer. I don't expect you to know this, okay? This is orthopedics. You're all eventually going to learn more and more orthopedics as you go along, okay? But our residents know to order an X-ray, an internal rotation. But what study might be more accurate in finding a femoral neck fracture? A CAT scan, right? Higher resolution. Are we just going to do a CAT scan of the femur to look for a femoral neck fracture in everybody? No. But how many of your high energy traumas are going to have a CAT scan done of their abdomen and pelvis? A lot of them. So if you're going to scan the pelvis, why not make sure you include the femoral neck? It's almost always included, okay? So our residents carefully look at that study to look for the additional information on that CAT scan, okay? Same goes for a CAT scan of the chest, abdomen, and pelvis for a trauma patient. And we have a patient that's obtunded, we will scroll through those series to look for an injury to the spine because we might pick up, because it's in the same field of view, FOV, field of view, we may pick up a subtle injury to the thoracic or the lumbar spine if we look carefully at those studies. And the radiologist will look at those too. Anybody thinking about going into radiology? Maybe? Yeah. You're very young in med school. You got your whole lives ahead of you. Literally. It's pretty cool. You want to try to use that surrogate information to guide you. Okay. If this patient had some air showing up in the soft tissues here, what might that imply that you would have seen on the patient? Open fracture, okay? So this introduces another concept, okay? You ever heard of the term compound fracture? Yeah, forget that term, doesn't exist anymore, okay? The term is open or closed fracture, okay? And it just means that fracture is open in the environment. How do we treat that differently? Antibiotics, maybe clean it out in the operating room with sterile saline, maybe fix that bone because it's more unstable, the fact that it broke through. Higher incidence of infection, might check those wounds more carefully as time goes by, okay? So another descriptor of a fracture is open or closed. And then there's also a term called simple or comminuted. What does comminuted mean? Natural, right? Broken into a number of pieces. If it's broken at many levels in the bone, we might use the term segmental, okay? So these are all descriptors, okay, of how we would do this. Now, this patient, okay, is, how do you think they'll be treated for this injury? You might close, reduce them, okay? This is an adult, this person's getting surgery, okay? That's a surgical fracture in an adult. They get 2 plates applied, like you see here. Okay. If you see that same pattern and say there's growth plates like you see here, and that fracture is displaced like that, how does that fracture get treated? Close, reduction, and a cast. Okay. Because children, their bone will remodel. So if they heal and they're malaligned, their movement is not going to be affected. But someone an adult, if they heal off by 10 degrees here, they may lose rotation of their arm. And also it may take them a lot longer to get back to work if you put them in a cast. A kid, you can kind of tolerate that a little bit longer. There's a lot of factors that go into how we treat these things. This is an interesting example of what we were talking about before, where you look at the radius and the ulna and say, oh, those fractures look bad. But look at the distal radial ulnar joint. And the ulnar styloid is completely ripped off. What do you think is going on there? That joint's been completely disrupted. How do we fix that joint? Well, you can reconstruct those ligaments, but they're probably torn apart. The solution is to actually anatomically restore the position of the radius and the ulna relative to one another, put them in supination, because that's where they're generally a little tighter. You can even pin that joint and keep the pin in for a couple of weeks to let them start to heal and let that area stiffen up, okay? Because ligaments, when they are torn away, they will scar in a little tighter, okay? So going back to how you describe a fracture, okay? Up on this board, we have multiple examples of displaced fractures, okay? But you can also, when you call somebody and try to describe a fracture to them over the phone, you want to try to use the verbiage that is going to best communicate what's going on. Does anyone want to take a stab at this one? I'll blow it up for you. Where'd you go? We only have one view, right? One view is no views. Does anyone want to describe that? Which bone is broken? Ulna. Where's it broken? Proximal third, middle third, distal third? Proximal third. Good. Okay. Is it angulated? A little bit, maybe 12 degrees or so. Is it shortened? A lot. Okay. Shortening is a big problem. Okay, because that persists. And generally, when we reduce bones, we want to get the ends applied. So if you tell me something shortened, my ears are listening. Okay. How are the joints above and below? Distal radial ulnar joint look okay? The radiocapitellar joint's dislocated, right? How are we going to get that back in? Maybe traction. Okay. What do you think is the number one most important thing to get that joint back in? It's shortened too. It's dislocated and shortened. So you have to get the ulna out to length to restore that. Okay. So you would pull on it until you get it restored. That one probably needs surgery too. Okay. But that's how a two bone system works. And you really want to try to describe, what angulation looks like. All right. This one, if we were to describe it, this is shortened, it's angulated, it's also translated. Okay. How much is it translated? 100%, greater than 100%. Is this one translated? No, it's angulated. Is it a complete fracture? No, it's an incomplete fracture. So yet another way to describe this. I'm not trying to make this tricky, but if you think about it, that makes sense, right? You can look at it and say, that's complete, that's incomplete, that's translated, that's not translated. You could be displaced. When you're displaced, you can be just angulated. You could be translated without any angulation. You can be short without any angulation, okay? But they all are displaced, all right? So describing the displacement is the important thing. And usually describe the direction that it's displaced. So this one is displaced in the radial direction. This one is displaced in the radial direction. Okay, if you say medial and lateral, if you're talking about anatomic position, you'll always be right. But if you're not, you describe the bone. Yes. Yes, you could be translated without shortening. So if it's overriding, that's short, but you can be translated and be fine. And many fractures are. Okay, probably the most common type to see, would be translated, maybe a little angulated, but not short. And those are usually amenable to closed reduction. You know what reduction means? Reducing the volume, pushing it back into place. Okay, when you hear reduction, that means we're trying to put something back together. Dislocated joint, reduce it. Dislocated displaced fraction, reduce it. Okay, good. I want to be quiet for a second and take some questions. We've got like 10 minutes, so I want to make sure people get lunch. I know it's a little truncated. I know these examples were a little hodgepodge. We just pulled up whatever came up, but it gives you an idea of how we talk about imaging. Okay. We try to be very descriptive about what we see, and it's meant to be an adjunct to your physical exam and your history. 90% of your diagnosis in orthopedics can get made on history and physical alone. And your tests, which is usually like 3 blood tests, and your imaging are meant to help you differentiate between your competing differential diagnoses. You guys have heard the concept of differential diagnosis, I'm sure, right? So as you're thinking about it, you want to think about why did the person order this image, okay? And you should look at your patient's imaging. It's a little intimidating because you tend to think that I'm going to miss something, but the only way you get good at it is by looking at it again and again and again. And thankfully, when I was in medical school, there wasn't a million online images of this or that. You read about a condition, you want to see what it looks like. Put in MRI of blank, put in CAT scan of blank, put in bone scan of blank, put in blood work of blank, and you will come up, in every different possible venue, you'll come up with different things that you can look at. Okay. Good. Other questions?
So would you first reduce that in the OR, like get it aligned, and then with the reconstruction of the ligaments, or are you going straight to the OR? And
Great question. Okay. So probably you're going to try to deal with this as the patient presents to you. Okay. Because it's very uncomfortable to have them in a dislocated position. And the longer you leave them like that, what complications might you have? Potentially. Okay. If you eroded through the skin, swelling. All right. So by realigning it and reducing the volume, you actually help to arrest some of the inflammatory process, some of the internal bleeding by bringing the ends together. Okay. You also make the patient a lot more comfortable. And then by splinting them, you actually help to downgrade the inflammatory response and the pain associated with movement. Okay. So that fracture, you may not take to the operating room until they're available the next day. There may be more pressing issues on the same patient that you need to address first. So pulling on it and trying to reduce it, or at the very least splinting it, even if you don't correct it, is a kind and appropriate thing to do to them. Okay. So generally when someone comes in and they have a bad injury, we try to reduce fractures quickly to prevent a continuing injury from taking place, to help try to restore normal blood flow to that limb, because sometimes the limb can be ischemic, and then to reduce pain. Okay. And so generally presenting to the emergency room like this will not go to the OR like that. Okay. Something will be done. Good question. Other questions?
I have an adjacent question, but like what % of hardware is left in after a surgery, and like, is there any pattern to what's left in and what's not left in?
Yeah, so absolutely. So there's lots of different types of implants. That's a whole other talk, to go through. We do that in the boot camp with the fourth years. There's devices that go inside the hollow part of the bone. Okay, so in the medullary canal, and those are called nails. Okay, there are devices that go on the outside, like you see here, those that have screws going through them, those are called plates. Okay, there are external fixators which sit outside the body and have pins going into the skin. We use pins sometimes to hold things in place. And hardware can be taken out, but there are risks. It can be challenging. If it's not bothering them, you can generally leave it in. Okay, so these plates have a higher risk of neurologic injury taking them out than putting them in. Okay. And when you take them out, you leave a hole in the bone behind there that will take many months to heal in completely. And so you subject that patient to risk of fracture through those sites if you don't take it out, or if you do take it out. If you don't take it out, they are subject to fracture risk at the end of the plate, where there is a difference in the modulus of elasticity, for my engineers, between the bone and the metal. And so that interface can concentrate stress and potentially break. And you really have to look at the studies and say what's pro and con. Okay. There are devices that have to come out, things that are prominent under the skin. PEDS, we put a lot of flexible titanium rods into the bone. They have to bounce off the bone because you have to avoid the growth plates on both ends. But to fix a femur, we'll put a flexible titanium rod in that creates spring-loaded stresses on both sides. And those irritate the skin because they stick out of the bone. That's how they get locked in place. So we have to take those out. So 6 to 12 months, we take them out. Sometimes, I do a lot of surgery on the hip, and there are screws that hold that in place, and they bother patients, about 30% of the time. So I tell them 30% of the time, you're going to tell me to take these out. But if they don't bother you, we're not taking them out. Good question.
so being that pediatric bone remodels, what justifies the need for using a device?
Perfect question. Okay. So it really depends on what the impact of the fracture is. Okay. So if you think about a tibia, when it fractures in a kid, generally it doesn't shorten very much. It may be a little angulated, but it heals very well in a cast. So it probably doesn't make sense to put flexible nails into a tibia. there's a fibula that's usually holding it out to length and periosteum on both of the bones. The femur, if you break that, takes a lot of energy and there's no second bone. So the femur will angulate and shorten. So femurs almost always get fixed, kids and adults. Elbow fractures almost always get fixed in kids. And that is because if you leave them the way they are, they don't heal properly. They have limited range of motion in the elbow. It's just the patterns that happen, okay? So it is a pattern by pattern specific thing, but you can probably use some principles there. The younger you are, the more likely you are to be able to treat it non-operatively, okay? And the the kids are not going to complain about a cast. They're going to figure out how to get themselves around. It's not going to limit their ability to go out and earn an income for a long period of time. So you can treat kids differently, but they also heal better, more reliably. Okay, they have less comorbidities. They're not smokers. They have more periosteum with better blood flow. What makes a fracture heal is blood flow and stability. Okay, and you can give them stability with a cast. You can give them stability with a device. Okay, but there are indications for and against using them, and that's something that you learn, coming through and seeing orthopedic, rotations.
I'm worried, especially with a fracture like this, you have to be worried about nerves and blood vessels, especially when implanting the device.
Yeah, so great question. All right, so I'm going to start back with principles again. Okay, as surgeons, we have to know the safe ways in and out of the body and where all that anatomy is. You guys will learn that in that. It is very well conserved. Okay, and you have to know what the structures look like. You have to know when they might potentially be injured. So vascular and nerve structures, okay, you would like to know before you're going in if there's a problem. So you would get that from your physical exam. So regardless of the age of the patient, you would want to assess their ability to say, move the muscles innervated by the median nerve. Okay, so you might have them claw their fingers. Classic way to check the hand is have them make an okay sign. Okay, if they can oppose the tip of their index finger and their thumb, then their flexor pollicis longus to the index is working. The flexor digitorum profundus to the index is working. The flexor pollicis longus to the thumb is working. And so median nerve is fine. If I can cross my fingers, the intrinsics of my hand are working, my ulnar nerve works fine. If I can extend my thumb, my radial nerve is working, my extensor pollicis longus, okay? So I would want to know going in what my status is, okay? Vascular, I can check pulse, I can check cap refill. If I see an injury and I see an open injury with arterial bleeding, that artery probably needs to be tied off, okay? And sometimes people get cut on a piece of glass or something like that in the forearm and the radial artery is bleeding or their radial nerve is, their ulnar artery is bleeding. And if I tie one of those off, are they going to lose blood flow to their hand? Most of the time, no, but you have to know that there are different types of circulation to the hand. Somewhere the ulna is dominant, usually, okay? Somewhere the radial is dominant. But you can do something called an Allen's test, where you push on both arteries and squeeze your hand, okay? And if you release it, your hand stays white. And if you release the ulnar side and the whole thing pinks up, then your ulnar artery is providing adequate perfusion to the whole hand. And if I open my hand, keep my ulnar artery, and release my radial, and the whole hand perfuses, well, my radial artery is okay. I can actually tie one of those off, all right? If I saw a large hematoma expanding, in the forearm, usually don't see that, but in like the thigh, they're getting more and more swollen and the compartments are getting tight. I have to believe I've injured a branch of the femoral artery and I might need to send them to special procedures to embolize that part of the artery, okay? Pelvic fractures are notorious for having injuries to the external iliac vein. And so you have to be aware of what some of the patterns are, but you can generally have a good idea going in what you need to do. But then as the surgeon going in, you have to know what the safe approach is, okay? So when you go into the forearm, for instance, the distal 2/3 of the forearm, you're gonna find the brachioradialis, okay? And you're gonna find the flexor carpi radialis. And if you go between those, you'll find the radial sensory branch comes out into the brachioradialis here, you protect that. The radial artery is just on the other side of the FCR. But if you come down there, you're gonna be safe, okay? And you can peel back the quadratus, the pronator quadratus pretty safely. As you get more proximal, you have to worry a little bit more about the anterior interosseous nerve. But this is a surgical approach that's meant to protect those structures going in. But the answer is, it's variable, okay? Some injuries have a high rate of neurovascular injury. Elbow fractures in kids have a really high rate of neurologic injury. Displaced fractures of the cervical spine, as you might imagine, have a very severe rate of, neurologic injury, different type of neurologic injury, okay? So some of it's fracture specific. But from a principle standpoint, you want to be able to do an assessment to try to know what those things are before you start. Okay? We try to limit unknowns to the best of our ability. so we can plan. Planning is key. Okay, I think we're running out of time, guys. But I really appreciate having you. Was this useful? Yeah? All right, good. We can plan another talk. I know that, Peter, PJ, and, the ORIG group have really done a great job putting together a lecture series for you this year. Make sure you keep your eyes open for additional talks. Okay? Good, thanks.
I just want to introduce myself. Very nice to meet
Hey,
you.
pal.
Yeah.
Yeah.
I just have a question. So are most of these fractures, are they open procedures? Or are they
Over the both. So it kind of depends on what the implant is.